Okie dokie. So today we'll go over clotting, arteriosclerosis, heart attacks, congestive heart failure, shock, EKGs, and dysrhythmias. So just to start off, a little bit of physiology. So with the endothelium, just remember, I guess that prefix of endo always means like the inner layer, whereas exo or epi and those kind of things, those are always outer. And so when they talk about the endothelium, that's the inside lining, the right next to the basal lamina. So basal is another word for kind of like the inner portion. Think like basement membranes and things like that. And so with blood vessels, some have smooth muscles, some have more or less elastic material, and then they also have this outer adventitia layer, which is what feeds, like the blood vessels feeding will feed into through the adventitia, like the vasa vasorum feeding into the adventitia. When we talk about blood flow, there's two main types. So there's laminar, which is the pretty much standard kind of flow. So in the middle, it's a big push, a lot faster, and then everything else is all kind of parallel flow. Everything's unidirectional. Whereas with turbulent flow, you might see that a little bit in smaller arteries or larger, more so than like your larger veins. But, when you have turbulent flow, think like turbulence in airplanes, so it's just kind of bumpy road. All of the blood kind of goes in different directions, and it's not exactly as consistent as before. So this can cause problems physiologically. When we're talking about blood clots, there's this thing called von Willebrand factor, and it's important because it's going to bind collagen of the basement membrane, and it's going to help relate us to how clotting actually works. So the big picture for blood clots is that you have fibrin strands that's going to form a net that catches all of your red blood cells. So he talks about these intrinsic and extrinsic pathways that activate or feed into this common pathway. And so the intrinsic pathway starts from a different trigger than the extrinsic, but they both feed into the same thing to form that fibrin net in the end. So talking about it in a little bit more detail, with the intrinsic pathway, it's activated by contact with the basement membrane. So there's no sorts of factors that are floating around in the blood. It's actually just exposure of the blood to some sort of thing that's already circulating in the blood, like collagen, not circulating, just already part of the system. So you're disrupting a capillary bed, and blood leaks out, and that blood gets in contact with some part of your body that it normally isn't touching, and then it'll activate that intrinsic pathway up over here. And then on the right side, we've got the extrinsic pathway, which is activated by tissue factor, released by damaged cells. So these cells may or may not have undergone necrosis, and they release this special tissue factor that once it makes contact with the blood, then it activates that pathway. But again, they both feed into a common pathway, and most injuries actually have both. So like step one, if you cut yourself, that's kind of exposing the blood to the collagen or something like that. That's intrinsic. But then when your cells themselves start to die and release that tissue factor, then that starts to trigger the extrinsic. So in the common pathway, the main steps or the key factors are when you convert prothrombin into thrombin. So in general, when you have pro in front of anything, that's kind of the inactive form. So prothrombin becomes thrombin down here, and after it's converted into thrombin down here, it will help convert fibrinogen, the inactive form, to fibrin, the active form. And once you have fibrin forming, it'll cross-link, so they actually will link together and form this very comprehensive net that will catch all of the red blood cells and clot the blood. And in a lot of these pathways, you'll see calcium kind of all around. And so calcium is a necessary cofactor in these pathways. So there's two main drugs that can be used to kind of help with the clotting. So you can either have warfarin or you can have heparin. So if you have warfarin, it acts on all of these factors circled here in red. So 2, 9, and 10. It's a factor that it can take a little bit longer to implement itself, whereas with heparin, it's more fast acting, and it acts in what's boxed over here in blue. So 2A, thrombin, and factor 8. And then, so it inhibits this intrinsic pathway. And so that's fast acting. And then there's another drug or molecule called EDTA, which chelates or binds calcium, so you can't clot as well with that one. But the two main ones that you should know more clinically are warfarin or heparin to inhibit specific pathways. So yeah.
I doubt he would ask about
Mm-hmm.
it, but for some reason he said that it was 8, right, instead of 7.
7? Oh.
Mm-hmm.
He said to change it. Okay.
But I don't know if he just couldn't find the way he was trying to explain it during class. He would never ask about that, right? It wouldn't matter.
Right. I don't think so. I think he. Well, okay. So, I think it could be, something about this. Like, so heparin maybe 7 is that what he was? I think. So I'll double check and I'll send an email about that. Yeah, but so there's these different factors associated with platelets and clotting that you guys saw earlier in the year, I believe. So the ones to know are prothrombin, which relates with the extrinsic pathway, and that's with Coumadin and warfarin, versus prothrombin, partial thromboblastin time, PTT, which affects the intrinsic pathway, heparin. So, yeah, so heparin with the intrinsic pathway is factor 8, whereas the warfarin affects factor 7 for the extrinsic pathway, if I have it correct. But I'll double check. Yeah. So with the clotting in general, like if you have this molecule called plasmin can break up the clots, and to break up clots, it's good if you have what's called an ischemic stroke. So if you guys think back to what ischemia is, that's like a cutoff of oxygen flow. So that's some sort of clot that's lodged in the blood vessel and blood can't get through. So if you use plasmin can break up the clot. But if you have a hemorrhagic stroke, which is too much bleeding, and you break up any clots that would have been formed to stop that clotting, then you would cause more harm to the patient. So TPA, which is this tissue plasminogen activator, converts inactive plasmin, so plasminogen, into the active form. So TPA works for ischemic strokes, but not for hemorrhagic strokes. And there's a molecule called D-dimer, which you will probably see in some of the clinical cases mentioned. It's kind of like a diagnostic test, and it's high if someone has a lot of clotting going on in their body. Okay. Next, we have this thing called DIC, which is disseminated intravascular coagulation. And so this is a very tricky clinical manifestation to treat because it kind of toggles between too much clotting and too much bleeding. So there's a lot of different ways that it can activate, or this phenomenon can kind of occur. So one, you could have massive tissue destruction, and so that'd be like a crush injury if like a tree fell on you, or something hit you or something like that. Another way could be sepsis. It could be bacterial, like a gram-negative releasing some sort of toxin or something like that causing inflammation and tissue death. Or it could even be just other forms of endothelial cell injury. And ultimately, that causes the cells to release that tissue factor. And once that tissue factor releases, we start activating that extrinsic pathway, and we get widespread microvascular thrombosis. So clotting everywhere in the body. And if we've got a lot of clotting going along, we could activate plasmin to break up the clots. But at times, if you break up too much of the clots, you can actually just lead to too much bleeding. And then if it's too much bleeding, then you need to clot again. So that's kind of where it kind of goes back and forth. And then, so those are the things that you'd have to watch out for with DIC. So there's clots everywhere, so the blood isn't getting through. But then if you treat it, but you treat too much, then there's too much bleeding everywhere. And so it's a fine line between the two. Next we have Virchow's triad. And so these are three factors that kind of relate to each other and thrombosis. So remember, a thrombus is a clot. So let's start with endothelial injury. So if we have injury to the cell, we're going to release that tissue factor, and that's going to activate the extrinsic pathway, and we're going to have clotting. But we could also have some sort of abnormal blood flow associated with an injury. Abnormal blood flow could be like, in the case of an aneurysm, you could have like slow blood flow or turbulence. That could be different forms of abnormal blood flow. Or you could have hypercoagulability. So if the blood is more likely to clot, then it could just lead to increased clotting in general. So these three factors just kind of relate to each other. Next we have relaxation of vascular smooth muscle. So with smooth muscle, you have this thing called shear stress. And that's kind of like the idea of if you put your hand out and it was windy outside, you would feel something brushing over your hand. And so in the vasculature, what happens is if the muscle feels this shear stress, it kind of will start to signal upstream that you want more blood flow. So first, I think it's the precapillary sphincter that's going to open up, and blood is going to start spreading in. And from there, the endothelial cell is going to so shear stress increases, which causes the endothelial cells to figure out that someone needs more blood. And if someone needs more blood, the smooth muscles have to relax, and these arteries have to get bigger. And they get bigger by dilating. And if they dilate, more blood flows, and then you can kind of please everyone in the end. So again, it's the precapillary sphincters. They start to open up, and they kind of they start to feel the shear stress. Like these endothelial cells start to feel the shear stress. They figure out someone downstream needs more blood. The smooth muscle will relax. It'll dilate. More blood will get to where it needs to go. And then everyone gets happy. I believe he's probably told you not to worry about Berger's disease. Is that correct? So we're going to just talk about Raynaud's disease or phenomenon. So basically, this is a phenomenon that isn't too bad. I guess like it's not going to like kill you or anything. It's just it happens mostly in females, young females. And what you'll see are like they get white palms basically, and this can be because of vasospasms in their arteries or arterioles of the hand, and there's just not getting enough warm blood, and your hands just become kind of more cold. So it's just like a phenomenon that you might see, but it's nothing to really worry about. So arteriosclerosis, it's a more broad category, and all of these things underneath kind of fit into it. So there's atherosclerosis, arteriosclerosis is kind of the main thing. Arteriosclerosis obliterans and Makaberg's calcific sclerosis. So atherosclerosis is probably one of the ones that you might hear most of the time, so it's about 95%. So atherosclerosis deals with a thing called LDLs. So those are your low density lipoproteins. So quote unquote the bad cholesterol. So lipoproteins, it's like when you need to transport these fats across the these fats across the cell, you kind of conjugate them with a protein. And low density just means you have a low ratio. You're not taking much fat per protein. So it's not transporting across the cell very well. So like HDLs are better because you can pack a high density of fat per protein and get around the cell. So what happens if you have too much LDL, like especially if it's oxidized, it can't actually get digested by the macrophages. So macrophages will digest this or try to eat the LDL, and then it starts to get bloated. And then it actually becomes what's called a foam cell because it gets so bloated. And then the macrophage will die. More macrophages come, and then they also can't digest it either. And eventually they also become bloated. And eventually you have this huge pool of lipids that and oxidized LDL and dead foam cells or dead macrophages everywhere because they couldn't properly dispose of that LDL. So what ends up happening is that all of that LDL or all that lipid and fat, it'll just clog the artery. And when it clogs the artery, a couple different things can happen. Blood can't get through. If it ruptures, so there's a thrombus, a clot, and if it ruptures, it'll like lead to more clotting because tissue factor will get released, and that activates that like clotting cascade again. So yeah, clots are bad, and there's just different things that can happen because of them. So let's see. In general, what happens is because the clot takes up space in your blood vessel, the actual lumen, so the area that the blood is actually going through, it actually starts to decrease, and then less blood can go through. And that causes your blood pressure to raise and stuff like that because the area is getting smaller. And this is just a slide outlining. So like you have that plaque of lipids, and the plaque will rupture, and then eventually you can have pain. Angina is another word for pain, chest pains, or even myocardial infarction, depending on where that clot is. So this is a diagram outlining the different types of how it might actually manifest itself. So you could have a clot, and it starts to kind of harden, and it can be severe fixed coronary obstruction. So this is completely blocked off except for a tiny little bit. So it's very, very difficult for blood to get through. You could have some sort of aggregate that's there, and this, it can get, like, more can be built into it, so it's complete occlusion. Occlusion is blocking it. So if it's complete occlusion, no blood, and that tissue completely dies out, versus with the mural thrombus with variable obstruction, you can have this thrombus that's kind of hanging around, but then blood can kind of go through, but it's just difficult for like the blood to get through, so you start to feel like different forms of chest pain and stuff like that. So it's a partial thrombus, whereas this case was the lumen itself is just so small now that it's very, very difficult for a heart to get through, and it can lead to chronic ischemic heart disease. So very difficult for proper oxygen to circulate in the blood. So it's very easy for, like, once you get that initial clot, for everything to just start building, and a 60% occlusion could very well easily become 100% occlusion, you know. So two ways in which a ruptured erythematous plaque can kill. So you could have a pulmonary embolism, so the clot, it can go to the lungs, and so it's actually okay if clots happen in the lungs because they have a lot of heparin there to break up any clots, because you want to make sure that there's no clots in your lungs. But So the two ways that it can kill is like one, the occlusion, and two is if it's like a permanent clot, or if the clot breaks up and causes more clotting down the line. And so a clot that breaks off and starts moving down the line is called an embolism. And so you can think embolism sounds kind of like ambling just kind of walking. So remember, big clots, big problems, small clots, smaller problem. That's kind of an easy way to remember it. Hyaline and hyperplastic arteriosclerosis. So with hyaline arteriosclerosis, it's kind of a glassy kind of texture or look to it. And this can be seen with diabetes, and that's because the smooth muscle is constantly exposed to glucose. And so the lumen starts to narrow. And with hyperplastic, it's with high blood pressure in the body. So the smooth muscle is starting to get stronger and stronger, and that's by hyperplasia. And so little blood gets through, and it's seen in malignant hypertension. So hyaline, just remember glassy, diabetes. Hyperplastic, high pressure. Medial calcification, it's also good to know the difference between arteriosclerosis obliterans and the Macabergs. So with the first one, with the obliterans, you see luminal narrowing. So that's the obliteration in this case. And then with the Macabergs, that's without luminal narrowing. And a question that he might just ask on the exam is he might like put some sort of definition that's like, some sort of sclerosis, like arterial or atherosclerosis with or without luminal narrowing, which one is it? And it's just a matter of identifying, is it this one or is it this one, or was it any of the previous, like hyaline versus hyperplastic? So it would be like a pretty straightforward, just lining it up, like which one would go to which definition, I guess. So aneurysms, it's kind of like a bulging of the blood vessel. And so when you have the bulging, it increases the radius, which increases wall tension and likelihood of rupture. And also he does mention what's called a dissection, and that's when blood kind of gets in between the tunica media and the adventitia, so the two outer layers. And all he wants you to take away is that if you get a dissection in the heart, it's bad. In the aorta, it's bad. So moving on to the next set of cardiovascular things. So when you have that plaque that starts to obstruct coronary blood flow, you could have a stable plaque which has that smaller lumen again, and blood can get through, but it's just going to hurt, so stable angina. But if it's unstable plaque that can rupture, or there's like clots everywhere, then you can get some sort of heart syndromes. And so you can have ischemia, transient or sustained. And if it's transient ischemia, then it can lead to unstable angina. Or if it's sustained, you can have myocardial infarction and inflammation and necrosis. So the cells can start to die because of the sustained ischemia, like no blood at all. No blood, no oxygen at all. So if you get to a certain point, some of your myocytes, the heart cells, they will be in this quote-unquote stun phase where they just stop working, stop functioning. But also they can hibernate, and they can also start to remodel themselves. So it's just a matter of like, so they can remodel themselves after a heart attack, but not particularly well. But it's just kind of some form of keeping the heart alive. So they do what they can to survive.
What's angina?
Angina is heart pain, or chest pain, and then you can have stable, unstable, or this other kind called Prince metal angina, which are these vasospasms. So it's not due to plaques, so not due to clotting, but it's actually caused by like overconstriction of your blood vessels that causes the pain, and that's more random. Whereas stable angina or unstable, it just has to do with like the blood is or is not going through properly. You've got a clot there, so it's kind of hurting because of like that pressure. But then Prince metal, overconstriction, and it's like a squeezing like pain. So the left ventricle is the most at risk for a heart attack. Most of the blood goes through here. And then that blood has to feed through kind of the rest of the body. So with EKGs, I'm just going to transition now. With EKGs, if you guys remember, it's all about the electrical signals, electrical impulses that have to go through the conduction system, conductile cells of the heart first. And then after the conductile cells kind of activate, then you get the actual muscle heart cells, cardiomyocytes, to actually contract. The muscle contracts after the conductile cells get that electrical impulse. So with the P wave, you get an atrial depolarization. And so remember, depolarization, you can kind of correlate it to contraction in this case. So if the atria is depolarized, then it will contract. So that's your P wave. It goes first. Because remember, if you think back to Wigger's diagram, you do the atrial kick to top off the ventricles. So they're completely full. And once the ventricles are completely full with blood, then they get an electrical signal to say, hey, you need to now pass that blood on to the next phase. So either pass it to the lungs or pass it to the rest of the body. So then you get this ventricular depolarization with the QRS phase. And then once it contracts, it has to rest to allow it to refill and allow everything else to kind of get the blood and starting over. So then you got a T wave for ventricular repolarization. And then you start all over again. Atrial kick, QRS, so ventricle contracts, and then it rests. And that's time for filling and everything like that again. And then these are all just different things that can show up. So ST elevation is probably the biggest one to know. And ST elevation is associated with heart attacks. So you'll see that in clinical cases. It's kind like there's a clinical case called like STEMI, so ST elevated myocardial infarction or something like that. So the highest risk for having a heart attack is if you've already had one in the past. So the primary prevention is you prevent the first heart attack. Secondary prevention is you can use drug treatments to kind of see if you can like lower your blood pressure and stuff like that. So like those kind of treatments, it's difficult to say like how effective it is for everyone, but you know, it's like taking aspirin daily. It may or may not necessarily help like everyone, but you know, it's at least like a couple % chance increase over the normal. So you have these serum enzymes that change only after a myocardial infarction. So sometimes in a clinical case, you might see like elevated CK. So CK is this creatinine kinase. So when a cell dies, protein starts to leak out. And so certain proteins leak out after this myocardial infarction. So there's like a CKMB, which is a cardiac isozyme, MM for the muscle, and BB is for the brain, and that's just like little ones that are just kind of here. Troponin also peaks before a CK in this like little graph, and troponin and myoglobin, they just aren't enzymes, they're just other proteins that are just in the cell. But basically an EKG is your quickest test for a heart attack, and then these lab values, they can kind of confirm or help point you in that direction, like if you saw it on a lab chart. Next we have just what happens when you have a heart attack. So after a heart attack, like your neutrophils, that's all these like little black dots that you see, they start to clean everything up and they're preparing for repair. And so you're losing cardiomyocytes and you're gaining collagen that kind of takes up the space that it was there before. And the problem with getting collagen formation is that the heart can't actually contract as easily now when you have collagen rather than the cardiomyocytes. And so other complications would be if a valve was actually cut. So if you remember last time we talked about the papillary muscles, and so those are the muscles that make sure your valves stay closed and they make sure blood flow is unidirectional. So if they get damaged, then you can have what's called a prolapse. So the actual heart valve will invert and blood can rush backwards, and then that turbulent blood flow can lead to death. Different complications that you'll see. So with heart failure, with a myocardial infarction, that's your heart attack. Blood isn't getting to the left ventricle, or the left ventricle isn't pumping the blood out. You could have ischemic heart disease or coronary artery disease, where you're not getting enough oxygen because you're not getting enough blood downstream to where you need it to go. You could have hypertension, which is just higher blood pressure, so it's harder for the cells to pump blood. And you could have valvular heart disease, or like a stenotic aortic valve, so it's just harder, it takes longer, more effort for the blood to pump. You could have intrinsic cardiomyopathy, so it could be a genetic disorder, or you could have myocarditis, so an autoimmune infection or an infection that causes some sort of attack against your own heart. So different ways the heart can fail, but they're kind of under this broad umbrella. So with Frank Starling's law of the heart, in this chart, I think I included it on my cheat sheet. So with this one, it's telling you on the bottom is the left ventricular end diastolic pressure. So it's kind of relating like your preload, like how much blood is in the heart before it contracts, and the cardiac output. If you're, like how full is your left ventricle and how much can it pump out effectively. So you have this normal, so you have warm and dry. So I think he characterized 4 different ways, either cold or warm versus dry versus wet. So warm and dry is kind of like meaning the body is warm, you get enough blood, you have a high enough cardiac output, and you're dry enough in that you're not overfilling the heart and you're not too full or anything like that. You don't have edema or anything like that. So that's where the normal range is, warm and dry. You have this warm and wet when you have edema in the heart or in the cells. You can have cold and wet, so not getting enough cardiac output, not enough blood getting to the rest of the heart, or cold and dry, so not getting enough blood, but you don't have edema. So with the idea of preload, more blood in, more blood comes out. But it can be a problem if you have high pressure that prevents you from properly getting the blood out and stuff like that. And so these arrows on the diagram, they point from say we're starting here, they kind of tell you which direction drug treatment will get you. So a digitalis will cause this cold and wet to go warm and wet. So is better for contractility, so it's better for cardiac output. A nitroprusside or NO donor, nitric oxide donor, that's this line right here. So it causes a cold and wet to become warm and dry. So it improves the pressure and it gets more blood out to the system by causing vasodilation. So if the arteries dilate, more blood can get out. If they dilate, they're starting to release pressure because it's not as confined to a small area. And then next you have a diuretic. So a diuretic would cause this cold and wet to go cold and dry. And so you're losing fluid. And so if you lose fluid, you lose preload, so it's less pressure. But it's not exactly helping your cardiac output, but it's just less pressure. Okay? Let's see. Next we have the vicious cycle of systolic heart failure. So if you have a heart attack, the heart can't pull. It's not as contractile anymore. So you can't contract and you can't eject as easily. You can't. Your ejection fraction decreases, and so you have more blood left over in your heart. And if more blood is kind of left over, then it'll also kind of feed back into the decreased contractility. On the other side, you can also affect your kidneys, because if you don't have good blood pressure, then the kidneys kind of want to increase that by increasing renin and angiotensin. And so remember, if you increase renin, you increase sodium retention, and you get more volume in the blood, so more blood or more fluid is in the system. And basically all of these kind of things, they all are very circular, and that heart failure with constricted blood vessels can lead to even more difficulty maintaining that cardiac output. So in general, it's just like you affect your pre and after load, so like how much blood is in the heart before you contract and how much is after, and then those both kind of feedback and like cause more damage kind of continuously. So it's a vicious cycle. With left ventricular hypertrophy, this is 3 examples of like what a heart kind of could look like. So it could be really muscular, and if it's really muscular, it could be like just very difficult to contract because it's just so thick. On the other hand, you could be so thin and just like with floppy lumens that like you can't even contract even if you wanted to, because it's just so weak and so floppy. And it's just overstretched, it's not efficient at all. A power athlete will have a pretty regular like lumen size, but they get very efficient pumping. So it's like a high preload, but it's like very efficient in how much blood they can like actually pump out per contraction. So, yeah. Pathophysiology of ventricular remodeling. So, epinephrine, can be a growth factor for the heart. Remember, if you see decreased pressure, decreased blood pressure, you'll increase angiotensin with that whole renin system again. So you increase aldosterone, which causes sodium to be retained. If sodium is retained, then you increase the blood volume, because like the water kind of follows, fluid follows where the it's like the high sodium content. You're increasing vascular tone, and you're remodeling the heart to be a little bit stronger with that like epinephrine. And it's pathological if the heart never rests, and that could be left ventricular hypertrophy, and that's just like another note. Atrial dilation with hypertension. So the left ventricle, if it hypertrophies, it becomes pretty stiff, and it's kind of hard to get the blood out. That will feed back into the atrium. So if it's hard for the left ventricle to like pump out what it needs to pump out, then there's more pressure building up in the left ventricle. And if there's more pressure in the left ventricle, it kind of will affect the atrium. And if it affects the atrium, it'll also affect the pulmonary system. So this is kind of leading into your next PowerPoint on like fetal heart circulation problems. And it's all about like if a problem occurs in like step 3, then like 2 and 1 also can get affected because they came before, and like pressure downstream causes pressure like farther upstream as well for the heart. And he'll go more in depth on that. So chronic cor pulmonale is another thing for right heart failure, which is secondary to some pulmonary problem. So if you think about it, if the lungs have a problem, it could feed back from the right heart, because the right heart feeds into the lungs. So that idea of like, if a ladder step fails, then it'll somehow affect the previous steps. This picture is again showing the different kinds of cardiomyopathies. So you could have dilated, so it's a large lumen. If it's a large lumen, it's like hard to kind of contract efficiently. You could have restrictive, where you have stiff walls that like just won't really contract very well. And same with hypertrophic. They're thick walls that are too thick to contract. So thick, stiff, and big lumen. Intrinsic dilated cardiomyopathy. This is like a genetic problem, and so you could have the left ventricle is dilated, and it's secondary to interstitial fibrosis. And so remember, when you have like some sort of heart problem and like you lose those heart cells, so because of like that cardiomyopathy, then collagen, which is seen here in blue, will kind of start replacing all of those red red-stained cardiomyocytes. Okay, so if you have what's called interstitial fibrosis, that's when you have collagen laying down, replacing that normal heart tissue, so it's very difficult for the heart to contract properly, which will lead to heart failure. Okay. Another way to think of it is that if you have some sort of hypertrophic cardiomyopathy, the muscle isn't contracting as strong as it should, and so it compensates by like trying to get more muscle, and if you have more muscle, it ends up increasing how much pressure is in the system, and you want to like vasodilate, you want to dilate the lumens so that you can get more blood through. And this is caused by like a defect in actin and myosin, so that muscle gets thicker and you increase the preload, so you want to like increase dilation to kind of help that. But at the same time, you also do get these again, like the collagen getting laid down. Actually, no, you get thicker muscles in this. So this is hypertrophic. The previous was dilated. So it's slightly different, but similar. Similar forms of cardiomyopathy. Myocarditis is all about, it's a rare infectious autoimmune disorder. So it could be like a flu, a viral infection causing your cells to get attacked, or it could just be some other infection. But basically, you're losing cardiomyocytes, and they're not getting replaced. In terms of shock is inadequate perfusion to the whole body, so you're not getting enough blood out to the system, and this can be cardiogenic, so cardio, heart problem, obstructive, so that's if there's something actually like in the way of the heart, like pumping the blood out, or hypovolemic, you just don't have enough blood in the system, and that could be caused by dehydration. It could be neurogenic, so because of the autonomic nervous system, you're not actually getting the proper factors out to the heart to say like you need to pump this much blood and stuff like that. So it could be because of, let's say, a spinal cord injury that causes decreased blood flow in the system and lower blood pressure. Next, you could have anaphylactic shock. So that could be sudden acute systemic inflammatory response, and that could lead to blood getting. So there's a system-wide loss of blood, and blood could just kind of get into extravascular spaces, and that decrease of blood everywhere has your blood pressure decreasing. And lastly, sepsis or septic shock. Think back to DIC. So it's triggered by infection. So like that bacterial gram-negative LPS kind of lipopolysaccharide infection could cause some sort of septic shock. Okay, moving on to EKGs. So there's a whole bunch of different heart problems. So remember, P wave, atrial contraction, that's when the SA node fires, sinoatrial node fires. That's the very first signal. It tells the atria to contract. Following that is the Q wave, which is signaling the ventricular septum. So it's going down to about to tell the ventricles to depolarize with the R wave, and then the ventricles contract and eject blood. And then the T is when the ventricles are repolarizing, and you'll also see sometimes a U wave, which is for the repolarization of papillary muscles. It's pretty insignificant. So this figure is just kind of lining up where we're kind of orienting ourselves. But the SA node is up top in the atria, near the atria, right? So you get the action potential that is like traveling down in the body. And then you have like this QRS when the ventricles contract. And then you have actual contraction. And so just if you can line up like where all the arrows are going, that can help better orient you like what is actually happening. If you want to see like, oh, this is the P wave, this is the QRS, like what is actually going on concurrently. Again, we said this before, but an elevated ST is when the ventricles are slow to depolarize over long periods of time. And what can happen is a large number of cells don't get the blood that they need. And this could be an indication of heart failure, and most likely is. So there's all these different types of rhythms, and for your cheat sheet, I think it's just easy to like shrink down the image and just like post them all on, basically. It's not too difficult, like to just shrink it down and post it on there. So sinus rhythms, tachycardia is for increased, so tachy is fast, so fast heart rate, versus brady, which is slow heart rate. Atrial fib, so your cells are just randomly firing and there's no unified P waves, so it's just kind of like a bunch of P waves are firing, and eventually you get QRSs kind of in response to one of those P waves. Atrial flutter is if you had a cluster of dead non-firing cells, so then like the AV isn't really picking up on your signal, so then it fires every, let's say, fourth contraction. Atrial tachycardia, so the atria is like contracting a lot faster than it should, and that could be because another cell is firing separate from like that unified P wave. So something else besides that SA firing set of cells. Junctional refers to the AV, when the AV node is the pacemaker. So remember, the AV node can contract by itself, but because the SA node has like a stronger signal, that's why we normally follow the SA. So if for some reason the SA node has been damaged or is compromised, then the AV node is like, oh hey, we still need to contract, so we're just going to do it ourselves. So you don't see a P wave, and it could be accelerated or it could just be regular. You could have ventricular rhythms, so you don't see a P wave, and again, the ventricles say like, oh, I'm just going to fire whenever. So you could have ventricular tachycardia, which is very, very bad for the patient, like most likely leads to death. And then, or just idioventricular, so just kind of randomly, just very slow. Premature contractions, so this could be like, you see a P wave, and then you see a QRS that just kind of fires quickly, and then you'll see a long delay before the next time it fires. Premature junctional contraction, you don't notice a P wave before a premature QRS phase, so the AV is just firing, and it's almost like that heart skips a beat thumping kind of phenomenon, and that's because like you fired here kind of prematurely, you didn't really see a P wave, you just went with it, and you went with it early so that like you had like a long delay leading up next time, and this long delay just means like a lot of filling, so that's why like it'll feel like a thump. With premature ventricular contraction, you'll have a really big QRS, but then you'll have this long filling time that also can just go like a lot of extra filling, so very strong contraction afterwards, and that's that extra filling boom kind of feeling. Heart blocks, so there's first, second, type 1 and 2, and then third. So first and third are pretty are a little bit easier. So the first degree is when like the AV node, it's just tired, so it kind of goes, but it's just a little bit slow to reacting. Okay, so P wave, a little bit of delay, and then it goes. A third degree is when you have completely unconnected P and QRS waves. So the P would just be here, and the QRS could just go right after, or it could just skip it altogether. It just fires on its own. You don't notice that AV and the ventricle just fires. Second degree, type 1, is when the PR intervals, they start increasing until a QRS is missing. So the AV is like getting slower and slower. So first you hit it, a little bit of delay, you completely missed it. You hit it, delay, completely missed it. Whereas type 2 is when you've got a normal PR kind of interval, but the QRS only responds to like every third P wave. So it's like, I responded, I didn't, I didn't, I did, didn't, did, something like that. Ventricular rhythms are the ones that you never want to see. So ventricular fibrillation. So if the heart just starts contracting all on its own, if it's very, very slow at contracting, like minimal at all, or not contracting at all. Valvular disorders. So, is this where you guys left off in class, or you guys still had a couple more?
We did that and the next slide.
Okay, so pretty much almost done here. Okay. Okay, cool. So valvular disorders, you've got either an insufficiency or a regurgitation. So insufficiency refers to something doesn't completely close like it should. Regurgitation is when the fluid moves in the wrong direction. So we'll kind of get more in detail, but this kind of slide is just like your prefacing for what's going to come, but you have to be able to know the difference between the mitral, which is the equivalent of the tricuspid on the right side, is an AV valve, versus the aortic, which is the equivalent of the pulmonic, the semilunar valve on the right side. So problems that you might see. So stenosis, you're not opening properly because you're very stenotic, so stiff. Insufficiency, you're not closing properly, which can result in regurgitation, so the blood will go in the opposite direction. And then you get different murmurs depending on like when something happened. Let's see. So stenosis results in pressure problems, and regurgitation is more volume problems. So stenosis, it's hard to pump something out. Increased pressure builds up. Regurgitation, like your blood went in the opposite direction, that's a volume problem. Common causes could be like a mitral valve prolapse. So if the valve inverted and the blood went backwards, you'd hear a mid-systolic click sound. And then you could have calcification, vegetations, and congenital valvular malformations, which we'll get to in a second. So, okay, with mitral stenosis, so that's like through the mitral valve, it's difficult for blood to get through from the left atria into the left ventricle. So in this case, the left atria isn't emptying properly because the valve is like thick and stiff, so you can't actually get the blood through it. And then you can have the left atria have more fluid inside, and that volume increases the preload, okay? And if the preload increases, that can back up and cause pressure on the lungs, which can cause edema. And if it causes edema, you can have less oxygen because it's like fluid is occupying the space that the lungs would normally have, and also increased resistance, so it's just difficult for them to contract. And increased pressure and like harder for the lungs to function, that feeds back on the right ventricle, which is like directly in front of the, directly feeds into the pulmonary system. On the other side of this diagram, we have decreased force of the left atria, so it's not able to contract as hard. And if it can't contract as hard because it's overly full of blood through a thick valve, then you get less blood that goes out from the left ventricles, and less blood that goes out from the left ventricles is like left ventricular failure and less oxygen supply for like the whole body. So lung is filling with fluid and just problems everywhere if you have stenosis in like a very key place. So bad valves, you can replace them, or you have to replace them. Mitral valve prolapse, so again, a papillary muscle gets damaged, so then like the valves open up in the opposite direction, and then you get tissue opens in the opposite direction than it should have, so blood can kind of go in the opposite direction. A systolic murmur is when blood is squeezing through somewhere and it takes a lot longer for ejection. Let's see. Skip this slide. So you might get what's called calcification, and calcification is kind of like your bones, your teeth, that's getting harder from calcium. But what happens is if you have all of this excess calcium floating around in your system, it can kind of seal your valves, and so they won't contract as easily. And these damaged valves develop these little leaflets that are kind of form along the way, and it's just difficult for them to open. You have this thing.
We
No,
haven't done
we've not done that.
Yeah. So I mean, this will just be kind of like a preview for next time again. Yeah.
You can keep going. Whatever you want.
Yeah. So rheumatic heart disease, and we can cover this again on Monday. So rheumatic heart disease, he'll talk about autoimmune disease. It's an autoimmune disease secondary to strep throat. So you have a streptococcal infection that it will produce antibodies, and these antibodies, for some reason, start to react against yourself after that strep infection. And when you have that strep infection, it'll, cause other forms of damage to the heart. And you get forms of regurgitation, so fluid starts to go in the wrong direction. You have another thing called infective endocarditis. So for some reason, you have endothelial cells that get damaged. When they get damaged, you start to form thrombi, if you remember again. So like tissue factor forms thrombus, extrinsic pathway. Once you start clotting, you might get it's non-bacterial at this point, but if for some reason some sort of pathogen enters your bloodstream, it can cause bacteremia. So blood is now infected by a bacteria, which can cause a whole bunch of other problems down the line. You can have non-bacterial endocarditis. So you form these little like leaflets all around, and it's kind of like a scab. You could have infective endocarditis, so you destroy your chordae tendineae, and then the valves will regurgitate, and it'll be just very difficult to open and close valves properly. And then you can have this Libman-Sachs endocarditis, which has like these small vegetations like all over the heart valves. And rheumatic heart disease also has like little leaflets, again, that form because you're just attacking and they kind of form. And basically, depending on where you are that you see a problem and what kind of problem it is, you either classify it as a systolic or a diastolic murmur. And so stenosis, remember, blood can't get through as easily. Regurgitation, wrong direction. And then continuous murmur, you'll talk about something called a patent ductus arteriosus. So a duct is always open, so you're hearing blood going through all the time. And you have, besides S1 and S2, which are for your normal like AV and SL nodes closing, or valves closing, then you have an S3, which is rapid filling, and that's when your atria rapidly fills to your ventricles, or an S4, which is at the end of diastole. If you hear it, it's a pathologic heart sound. And that's it.
Thank you.
Thank you.